الرحمن الرحيم والصلاة والسلام على سيد المرسلين سيدنا محمد صلى الله عليه وسلم. نبدأ اليوم إن شاء الله المحاضرات بدكتور خالد الفارس. Dr. Khalid, he is graduated from King Abdulaziz University in 2013. He has the American Research Fellowship from Johns Hopkins Medical Institution in USA in 2017. He got the American Board of Internal Medicine from Ascension St. John Hospital, Detroit, USA in 2021. And he got the American Fellowship of Endocrinology, Diabetes and Metabolism from Henry Ford Hospital in 2023. And all we know, Dr. Khalid Al-Faris, he is Assistant Professor and Consultant of Endocrinology, Diabetes and Metabolism in Faculty of Medicine, King Abdulaziz University in Jeddah. Today he is going to start our session with his lecture about the management of diabetes, the promise of all.
Thank you. Assalamu alaikum, sabah al-khair. Okay. Good morning, everybody. Thank you very much for showing on a Saturday morning for a talk about artificial intelligence. Thank you for the online audience as well for waking up early for the lecture. طبعا talking about using AI is very interesting, but talking about it, the technical part, is very boring. So especially if we're not in a computer science audience or symposium. So I hope you bear with me. I don't want you to look at this as a typical lecture. It's more of a news report ولا نشرة أخبار about what's happening in AI. What are we currently doing in AI? So I have no disclosure for my talk today. So why do we need to improve our DM care? Okay, why do we need to do anything regarding DM? Because 50% of adults in the US, they still have an A1C above 7%. So half of people with diabetes, they're still uncontrolled. It caused 6.7 million deaths in 2021. That's one death. Just think about that. One death every 5 seconds. It's scary. It's very scary. And when we're trying to use technology and we're trying to adapt technology, 51% of people reported inadequate training. Here's the CGM, here's the technology, good luck. Okay? So that part is on our end. So what are the limitations? 50% of patients fail to adhere to medication due to cost, due to availability, side effects. 30% of insulin users have severe hypoglycemia annually, and which, as you guys all may know, it's a life-threatening condition. So what are the limitations? There are many limitations, new treatments, complex monitoring requirements, multiple data silos. We're living in a world with huge influx of data, limited population intelligence, evolving evidence-based. We're having trials every day about AI and everything else. Limited specialist access. You guys all know, you guys are all expert in this. Not everyone who treats diabetes knows how to treat diabetes. Short appointment times. And unfortunately, none of us have the luxury of spending and the time that we want, the time and we need with our patients. So let's start with a philosophical description. What is intelligence? So intelligence is the ability to acquire and apply knowledge and skills to reach one goal, solving a problem. You recognize a problem, you try to come up with a skill based on the knowledge you have to solve the problem. And that's the basic milestone and growth of kids. That's what happened with their growth. Now, what is artificial intelligence? Using the same thing, okay, but with machines. It's describing machine or computers that mimic the cognitive function, the solving problem capabilities we as human beings do, with an ultimate goal to maximize the chance of solving a problem. So I love history. I have to start my talk with history, no matter what I'm talking about. But this is just a brief milestone, brief glimpse of the major milestones in AI history. So it starts with the Turing test. That's in 1950. This is the first time the concept of human versus machines came into place. So what we did there is we had which we call it a Turing test. Alan Turing is a gentleman who came up with this test. So there's an interrogator who's blinded, and there's a wall in front of him, and he's receiving two messages, one from a human being and one from a machine. And he tries to discriminate which one is a machine, which one is a human. If he was able to do that, that's a positive test. So the machine failed. Okay? So the machine job is to prove that I'm not a machine, I'm a human. So I can convince that interpreter that I'm a human. It's interesting. 100 years later, we're doing the opposite now. We as humans trying to prove that we're not machines, we're human. I'm not a robot, okay? And I have no clue, and I cannot get my head around this. Fast forward till 1997. This is the first time machine defeated humans. This is Korpakov. He's a world champion of chess. This is the first time computer and AI defeated chess world champion. And now we're living in the ChatGPT plus era with all the chat engines, OpenAI, and artificial intelligence. Okay, so what are the types of artificial intelligence? Very basics. We're not going into any IT stuff here. Machine learning, deep learning, and natural language processing. So I will start with the natural language processing. So this is an AI helped computer understand, speak, write in human language. Let me give you an example. Back in the day, if you want to use your computer to make an appointment, you're going to say Sunday, February 5th, 6 p.m., doctor appointment, Abdulaziz, Hira Street. Okay? But now, hey Siri, remind me of my doctor appointment on Sunday at 5 p.m. This is basically what NLP. It changes from a basic command word by word into a regular dialogue and can translate it into function. Siri, an example, and the 24/7, the Radd al-Ali في البنوك and the customer service agent. Now, what is machine learning? It learns from data to make decisions. The more you feed it, the more it can analyze and come up with solutions. Basic example, Google. If I want to Google right now a coffee shop, it will know my location, so based on that, it will choose the coffee shop that's next to me. It will know my previous reviews and previous visit, and based on that, it will choose a specific coffee shop. Same thing for Amazon. If I bought microwave, the next day I go into Amazon, it will suggest other kitchen gadget or other kitchen accessories. This is basically machine learning. Another example, Netflix or any platform. You saw a French movie, it's more likely to recommend another French movie afterwards. Deep learning, it's the same thing, but on a much deeper scale. They use a concept called neural network, which is inspired by human brains. It's the same thing, input and output. But in between, you have an influx of data based on previous history, previous experiences, and so forth. Biggest example that's been there for years, autopilot. Flights that the pilot's usually hands off, and it just continues on its own. Automated cars. Now Netflix again, but what I mean here, it will not just suggest the next movie, that's machine learning. The deep learning, it will suggest a playlist of 10 movies based on the 20 movies that you watched before. So this is deep learning. For football fans, in the World Cup, the semi-automated VAR system, the video assisted refereeing, they use dozens of cameras around the football pitch, the football field. And they had 10,000 surface points on every player's body, including the ball. When it's time to take an offside decision to analyze it, they analyze that influx of pictures. And based on the cameras and based on the position and all that, they come up with a decision. Now, this by itself led to a decrease, this is studies proven, the decision time from the moment the referee blows a whistle to the decision of offside, it dropped that by 31 seconds. 31 seconds is a lot in football. Okay, this is just showing you the world of AI we're living in. This is Google Trends, basically how many times people search for AI. And you can see after 2020, it just boomed upwards. Okay, AI in medicine. What are common example? ECG machine interpretation. We had that for years. The thing on the top in the middle. This is likely atrial fibrillation. There is an interference. There's a left ventricular hypertrophy. This is all AI. Robotic surgeries, dermatology, pattern recognition, radiology, which is a huge topic about radiology and AI in the field of radiology. Chest X-ray, bone age, diagnostic of genetic disorders, smartwatches, AFib, and fall detection. It now can detect if you fell. Is it reliable? Is AI and ChatGPT reliable? Can we trust it? Well, this is an interesting study. They had the ChatGPT take the USMLE exam. So this is known as one of the most difficult exams in medicine worldwide. So they had ChatGPT take this exam recently. The passing score, it depends on the year, but it's around 60%. The ChatGPT scored 60%, so meaning that ChatGPT passed the USMLE exam. Okay, what are AI examples in education? How can we use that? This is very interesting. They asked two groups of physicians, medical and surgeon, to write 50 board-like exam questions. The medical physicians will use Harrison, which is a principle of medicine, and Bailey and Love was used by the surgeon. And also they asked ChatGPT to do the same thing. There was no statistically significant differences between the quality of questions from ChatGPT and from physician. Not only that, when they asked the blinded assessor, can you guess which one was a ChatGPT and which one was a human written question? The success rate of guessing correctly was very low. So they were not able to differentiate. But more importantly, the time. Human examiners took 3 hours and 30 minutes to write 50 board-like questions. How long do you guys think the ChatGPT took? Well, way less than half. Only 20 minutes and 25 seconds. 50 board-like questions. Now remember that ChatGPT are utilizing the books. You're not just giving a command, hey ChatGPT, write a board question. No, you upload the book and you ask ChatGPT to write a question from the book. Let's go into endocrinology now. How can we use, what is already being used in endocrinology? Facial recognition. So they ask AI, they show the pictures of 20 female with Cushing and 40 sex and age-matched controls if they can able to detect a Cushing disease patient. Well, the software were able to detect 85% of patient and 95% of controls. That's an accuracy of 91.7. Same thing for acromegaly. They fed the AI pictures of 500 acromegalic patient and close to 600 normal subject. Look at this. There's not a lot of tests in medicine that have these numbers of sensitivity and specificity, and also positive predictive value and negative predictive value. 96% across the board. There's few tests in medicine that can meet those numbers. This is one of the interesting areas of AI, the radiology. This is thyroid nodules, since we're speaking about endocrinology here. They trying to assess the capability of a radiologist versus AI in detecting thyroid nodules. So they ask a junior radiologist to detect further multiple ultrasound pictures of the thyroid. The sensitivity was as low as 64%, but up at 96%. Senior radiologist, a little bit better, 75% to 97%. But when they use the CNN, which is a model and a deep learning model, it showed that 74 to 90% sensitivity. Now remember, we don't necessarily need a better test. We just need something as good as the senior radiologist. More convenient, more availability, so we can widely use it. We don't necessarily need a better test. But not only that, when you ask the juniors to use the AI, the numbers went up to meet the AI and senior radiology percentages, which is extraordinary in my opinion. Okay, so now let's go into diabetes. So when we think about AI in diabetes, the first thing that came to mind is insulin pump, CGM, and all that. But this is only the tip of the iceberg. If you look at all the stuff that we can use for diabetes, we can use about pre-diabetes or management of medical nutrition, exercise. We can use about clinical decision support system, which meaning integrating AI into our electronic health record, image analysis, and we're going to show you some examples of that. Okay, screening. This is using a fob, which is fundus on phone. This machine is called fundus on phone. Basically, you buy it online, you slap your iPhone on it, and you just shine it on the patient's eye. And what it does, it can detect different types of retinopathy with very high sensitivity, and all of them were statistically significant, as you guys might see. But what's very important is the RDR, which is referable diabetic retinopathy. That's what we care about as a non-ophthalmologist, to know when to refer a patient to an ophthalmologist, to an eye expert. And look at the sensitivity, 99.3%, and strongly statistically significant. This is mind-blowing. Now, medical nutrition. So this app called Snap and Eat. So you take a picture of a plate, and it can tell you exactly what's on your plate. There's a piece of chicken, there's potatoes, there's mixed fruits, there's salad. Not only that, it tells you exactly the portion estimation, how many grams of each item, and it creates a label. Now, this is just a random number that nobody knows how accurate they are. Actually, it showed 85% accuracy in detecting 15 kinds of food. Now, this is very early on, but just remember, just think about having those high accuracy percentages early on. Now, this is specifically for carbs, which is, as we all know, very important for our type 1 population. What they did here, they took a 54 plated meals, and they took a picture of it, and they gave it to an app called GoCarb, or to a dietitian, a group of dietitians. Now, those dietitians was fairly experienced. They have a mean experience of 12 years, and they compared the result. And the result was mind-blowing. There's no statistically significant difference between the GoCarb app and the experienced dietitian. Now remember, this is similar to what we mentioned before. We're not looking for a better test. We're not looking for a more accurate test. We want something as good as a certified dietitian or experienced dietitian to be more available, to be more convenient, cheaper. You're on your phone, you can download the app for free or with a minimal cost. Now, the larger the size, the more difficult to estimate. And if you can see here on the graph on the top, these are the very dense carbs. And the wider the bar, the more high the estimate errors are. So rice, potatoes, pasta have the major variation. Again, this is very early on, but it's very promising. Health coaching. Now, this is a fully online, cloud-based coaching, okay? Personal training. And this is only 3 months data. This is changes from baseline only over 3 months. As you can see, the statistically significant part, the weight went down, the waist circumference went down, A1C went down, fasting glucose went down. It's only 3 months, okay? Now, monitoring, which is the bulk of AI. Now, we think about CGM the first thing when we talk about monitoring of diabetes. But I always like to show this to my fellows because this is one of my favorite studies. So what they did here, they had 2 groups of people on the exact regimen for type 2 diabetes. Exact number of medication, all of them without insulin, same baseline demographic, same baseline A1C. But the difference, on one group, they put a CGM, and the other group, the good old finger stick blood glucose. And what it showed after 6 months, the drop in the mean glucose across 24 hours. This is without changing anything in the management, just having a CGM versus regular checks. What that tells me, it induces a behavior changes. Okay, I'm eating a meal and it screwed up my blood sugar this day. I know this meal probably it's not the best, so I can avoid or minimize having that meal on a regular basis. Versus, I'm eating a meal that I thought it's terrible for my sugar, but actually it's not that bad. Maybe I can eat more of that. So detecting the blood glucose is not the AI. The AI is the prediction. Your glucose is slowly falling. It's falling. It's rapidly falling. This is the AI, the estimation, the prediction. Same thing for rising. Slowly rising, rapidly rising. Now, this is very early on. This is a wristband. No invasion. There's no microneedle. There's nothing. It's just a wristband that acts as a CGM. Now, this is achieved a MARD of 10.3%. So MARD is mean absolute reference. I forgot the D. Anyway, so what this means is that the relation between a CGM and the finger stick numbers. Now, usually, most CGM to be reliable, the number should be less than 10%. So this is 10.3%. Just to give you more context, the CGM we have right now, the Freestyle Libre is around 11, and the Dexcom is around 9.3%. Now, this is on a very small sample size, okay? And this is not just last year, this is 2018, so it's not very recent. Okay, now therapy. I'm gonna skip this. So this is a very sad study, in my opinion. So they asked 300 patients and physicians certain question: how many physicians, by the time you end your visit, have discussed the major principle of treatment? This is very sad. A1C target during titration. How many physicians had that discussion with their patient? Now this is survey filled by patients. 27% only. How many patients had discussion about their fasting target, their blood glucose target? Around 30%. How many had the anticipated amount of insulin to reach the goal? Only 13% of patients. They were talked to about the possible insulin dose that they might need. So this is 1950s. This is the first insulin pump. And this is the first portable insulin pump. And you can imagine. Now these, one of the most pumps that we have right now. We know insulin pump is highly effective. We're not here to debate that. Okay? And this is study, recent study, one of 100 study by our colleagues at the National Guard Hospital in Riyadh, looking at the A1C improvement with CSI, continuous subcutaneous insulin injection. And you can see the quite difference. It's pretty obvious. And this is nothing new. It just, to add to the flow of data that we have supporting this. But this is not the AI. The insulin pump, part of it obviously is the AI. In my opinion, the insulin pump is the hallmark of AI in diabetes. But this is the future. The only thing that insulin pump cannot tell right now is when do I start eating, when the patient starts eating. The whole idea of insulin pump is to mimic the human pancreas. طبعا خلقة الله سبحانه وتعالى. We're trying our best to mimic that as much as possible. So that gap is still there. But this is the first time that the AI based on trends and neural algorithms inserted on its system, it can detect when did the patient start eating. So this is 0 minutes, this is the meal time, the patient started eating here. And if you're using the meal detection technology, you can see the blood glucose is ranging nicely because the pump automatically increased your basal rate and it started giving microboluses. But if you have the meal detection technology off, you go into hyperglycemia reaching 300. The islet, the bionic pancreas, this is also the future of insulin pump. No basal rate, no carb counting, no correction. It's all algorithmic. It's all AI based on previous days, previous pattern, previous blood sugars. Now let's shift a little bit away from insulin pump. What other modalities that we can use AI in? Electronic health record. This is the University of Utah Hospital. What they did, they looked at patients that come in the hospital with diabetes and whatever admission reason they come up with. And all the patients that comes in, the EMR has flood of records. Their age, their gender, weight, different lab values, A1C, sodium, creatinine, GFR, microalbumin ratio, LDL, and so forth. And they put all this together into the deep learning system, and they come up with a proposal. For example, this patient, the system proposed, okay, metformin and SGLT2 inhibitor is a good idea. Why? Because the patient will benefit from low risk of hypoglycemia. The patient will benefit from reduced cardiovascular risk because he has an elevated LDL, for example. And the patient will have a reduced heart failure risk. Not only that, it tells you the thing to be aware of. The patient will be on metformin, therefore keep in mind vitamin B12 deficiency, therefore keep in mind diarrhea is possible, therefore, and being on SGLT inhibitors, keep in mind he's at high risk of UTI or yeast infections. Not only that, it can give you an estimated price, and if insurance covers it, and other alternative agents. Okay, complications. What is there to be used in complication? Well, there's different models and different types of complication that we can use AI in. But in particular, this complication, same thing what we used in the last study. It's just the influx of data we're trying to analyze and try to predict who is at high risk of certain complication. And if you look at the accuracy of this system in predicting ischemic heart disease, it's as close as 83%, which is quite significant. And if you look at the other numbers, although they are lower, but they're not anywhere below 70%, which is still not quite high, but at the same time not quite low for an accuracy. We can use it in predicting complication of medications or post-market surveillance. This is the study on the canagliflozin, which we know was associated with amputation. They looked at 18,000 patients who is on canagliflozin, and they analyzed different parameters, and they looked who had amputation, and they're trying to risk stratify. What are the factors that are highly suggestive of, unfortunately, going to have an amputation? And based on AI, they found out, which we know right now, is having a history of lower extremity amputation is the highest risk of having amputation from canagliflozin. And the second is loop diuretics and sulfonylurea. Okay, I'm going to skip this. This is currently being used in a lot of healthcare systems, which what we call a thermogram. So you take a picture of a patient with diabetes, you take a picture of their soul, and these are the control group, and these are the diabetic group. And based on thermogenesis, they were able to classify the patient as mild, moderate, and severe. Now, this is contactless. You just take a picture, no pain, you're not touching the patient. You don't need to go to see a physician. You can do it at your home and upload the picture to the system. And again, look at those numbers. There's not a lot of tests in medicine, again, that has this much accuracy, precision, and sensitivity. Okay, 95%. Now, we have challenges, obviously. Data quality control. Not every research center is the same. Not every policy is the same. Poor technology design. Again, we need a standard. Lack of clinical integration. Not all AMR are the same, and not all AMR are adaptable to AI. Non-adherence. We feel excited in using AI in the beginning, either patients or physician, but then we lose interest after a while. Imperfection of laws and regulation, which is a huge gap, not just in healthcare. This is a major concern of AI in any aspect. Future direction, we need algorithmic fairness, no matter if you're in a rural area or in a public or in a big or in the major of the center of the capital. Address the most crucial need. Do we need to work on screening, complication, management, and collaboration with other specialists, especially when it comes to diabetes. You guys all know it's a multi-system disease that involves multi-specialists and multi-modalities. So the million-dollar question, not just in medicine, in everything, will AI replace humans? Before I answer that, any of you guys are familiar with the trolley dilemma? Okay, I'm saying yeses. So this has actually been taught in psychology as well. I was actually talking to my nephew, who's 12 years old, yesterday. He studied this in school, which is interesting. So think about this. You are this gentleman on the lever, okay? And there's a train coming. Now, this track is closed, okay? There's a child playing here, and there's 5 childs playing here. And you have 3 options. One is do nothing and let the train go and kill 5 kids. Or change the latch so it can go to the blocked track and kill 1 kid and save 5. Or you can derail the train, let the train fall over and kill all the people in train. Now, if you ask AI, if you put this in any AI model, the answer will always be the same, to kill 1 child. This will always be the AI answer, because the AI will always choose the lowest minimal risk. But for human beings, this has been argued for decades. And I'm sure if I ask for show of hands, we're not going to agree on one answer. Someone will say, well, I will choose changing the lever and kill 1 child, because killing 1 child better than killing 5 kids. The second thing is, the second argument, no, I'm going to do nothing and let those 5 kids die, because that child was playing on a closed track. It's not his fault. He saw that track is closed, therefore I can play there. He's not at fault there. The third argument is derail the train, because if the train fall over, you cannot guarantee that they're going to die. There's a chance some may live, some may have disabilities, or if they died, usually most people on the track is adult. So you're saving kids instead of adults because they are the future. Okay? So this interaction, the human aspect, the judgment is what that AI will never have. Okay? And the most importantly on top of that is empathy. Our decision is driven by empathy. AI will never ever have empathy. As I said, it will always choose to kill the one kid because the minimal risk benefit. So I will conclude with this message to my fellow humans. AI won't replace you. Someone using AI will. Thank you very much.
Thank you, Dr. Thank you, Dr. Al-Faris, for this excellent, insightful presentation on crucial and timely topics. Your expertise and valuable perspective has certainly enriched our understanding of this very important topics. Now we'll move the second speaker, Dr. Nuwaid Al-Zaman. Dr. Nuwaid Al-Zaman, consultant endocrinology, Taiba University, Al-Madina, Al-Munawwara. Dr. Al-Zaman has his MBBS King Abdulaziz University, Jeddah, and internal medicine residency program in Bay State Medical Center, USA, 2012.